So as you've seen, him starting to have his heart attack, and then we'll see what happens when he gets finished here. So we're going to discuss the pathology of angina and MI, nursing interventions, signs and symptoms and treatments, and differences of angina and MI. Coronary artery disease, so impaired blood flow to the myocardium. Here it shows the normal artery and the narrowing of that artery, so the deposit of the plaque. So, people don't realize when they say, oh, I've got high cholesterol. To them, it's just numbers, right? So, as nurses, we need to let them understand, this is blocking your artery. This will cause you to have a heart attack. And I don't know if the doctors explain it enough to them when they come in with the high cholesterol. So what's our risk factors? We know that one is
smoking.
And that is
overweight. High blood pressure.
Now, who knows what that one is? Some of you are this.
Old.
No.
Anxiety.
Close. Nikki, you're funny. I know what you're feeling, girl. How about type A personalities? Majority of ones with heart disease or heart attacks are type A personalities because they cannot learn to relax, right? Too much stress, they just don't have the coping mechanisms to calm, right? So type A personality is a big risk factor. What are non-modifiable risk factors? What can you not change?
When you're old.
There you go, our age. What else?
Genetics.
Like your gender or your family history, yeah. So family history, we can't change. Well, I won't say we can't change our gender, but okay. I'm not allowed to say that stuff now. So anyway, those are non-modifiable. We can change, right? We can quit smoking. We can be on medications or try to lose that weight for that high blood pressure. And we can use coping mechanisms to calm our stress. Okay. So medications you may see them on for this is, of course, the statins. A lot of people can't take statins. A lot of people are allergic to them, so they may not be on the statins, but that is the class of the lipid-lowering medications. The bile acid, these are used to reduce low-density cholesterol levels. Nicotinic acid, these are like vitamin B3, used to prevent cardiovascular disease. And then aspirin, right? And then they may also, aspirin prohibits the platelets from sticking together and prevents that clot formation. Daily dose 75 to 81. Long-term use could cause bleeding, right? So you have to watch, again, what are side effects of these. So how are we diagnosing? We're going to see these repeated a lot for a lot of this. So your EKG, the exercise stress test, the echo, maybe some imaging, MRAs, maybe some CTs, okay? Angina pectoris, chest pain resulting from reduced coronary blood flow, which causes that temporary imbalance between the myocardial blood supply and demand. So we have three types we're going to go into here. Stable angina. This is the most common. So when they're having physical exertion, exposed to cold or by the stress, this is when they're going to start having angina. So how do we know it's not myocardial infarction? Because this can be treated, it's going to be relieved by rest and by nitrates. Okay, so people come into the ER. Harry Whitmer, I know you work ER, you see probably a lot. How many do you see come in with angina? They think they're having a heart attack, but it turns out to be angina. Do you know? You know, which is good they come in, right?
Yeah, majority of the people we see are either chest pain or COVID, so.
Okay. And sometimes that's together, right? So it's good they come in to make sure it's not a complete MI. But usually we give them a little rest, give them a little nitro, either under the tongue or a patch, and they're okay then. They're okay to go. So something's brought this on, let's treat them, and they'll be all right. Pritt-Smith's angina, that's unrelated to activity. So this often happens at night. So the sympathetic nervous system responds, promotes vasodilation. So all of a sudden they start having a coronary artery spasm. So it's pain, but it's not an MI, it's just an angina. Now we get to unstable angina. So the heart doesn't get enough blood flow. And oxygen, so this is a form of acute coronary syndrome. Occurs with increasing frequency, severity, and duration. So pain is unpredictable, and it may occur when they're at rest. So these are a higher risk for having that MI, or myocardial infarction, or you may hear it say AMI, acute myocardial infarction. So there's different things you're going to see it labeled as. So they're at a greater risk because their angina, the heart's not getting enough. It's not like completely occluded yet, to where they're having a heart attack, but they're having problems. So here's just kind of a different thing for you there. So stable angina shows how a little bit of ischemia, no infarct yet. So your EKG is still showing a normal rhythm, right? We're starting to get into unstable. You're going to see maybe some inverted T waves, maybe some ST depression, okay? So you see how the plaque is forming there and a thrombus forms around it. So you're starting to see they're going to have some problems. We're going to have to do something, right? Oh, I'm sorry, Summer. Summer had to leave us. Oh, goodness. Okay. All right. How do we diagnose this? Again, family history, right? Is there a family history of angina or an MI? Do they have a past medical history? Have they had a heart attack before? What is their risk factors again? Are they overweight, high blood pressure, high cholesterol? I'm going to do that 12 lead on them. They're going to do an echo, maybe a coronary angiography, okay, which is a CTA scan. Has anybody ever had a CTA scan? They're a little bit different than a CT scan. So I had one. My pressure runs low a lot. So as they're getting me ready to go through it, he's like, well, we're going to give you, oh gosh, now my mind went blank. They give it under my tongue to drop my pressure even more. And I'm like, oh, great, I'm going to code right here in the CT scan. But they watch it really good, and I did fine. But that's what they do. They have to have your pressure so low when they're doing this to watch what's going on in those arteries. So. And again, medications is nitrates. So nitrates are used to treat acute angina attacks and prevent angina. Have you ever seen anybody carried around their neck and a little lead thing hanging on their neck? They'll carry their little nitro pills if they start having chest pain. Beta blockers is a first-line drugs. Calcium channel blockers reduce that myocardial oxygen demand. And again, aspirin. We're going to reduce the risk of the platelet aggregation. I don't like how your book's set up because it goes back and forth here. So then we're going to talk about the acute coronary syndromes. which is unstable cardiac ischemia. It's not an MI, so it's the blood flow is reduced in there, but it's not fully blocked. So their chest pain may last longer than 10 to 20 minutes, and it could occur at rest. So you understand why they think, oh, I'm having a heart attack, this chest pain's not going away. Again, we're going to diagnose by that EKG, by that cardiac markers. We're going to get into those in a minute. How are we going to treat it? By the drugs, the beta blockers, the nitrates, heparin maybe. They may have a CABG procedure if their symptoms are bad enough once they go to the cardiac cath. So these are any of the syndromes that could cause this as your acute coronary syndromes. So our lipids, what's your cholesterol? Is your good not good enough? Sometimes it's not high. They want it higher than 40. That's a cardioprotective mechanism. Sometimes it's not. So then they tell you increase your exercise if your good cholesterol is not good. Exercise EKG, they want you to see you walk in to see what's going to happen if they would discharge you. But when you're walking, you run into SVTs, then they're going to have to do something before you're discharged. So that's your exercise EKG. This is a PTCA, percutaneous coronary angioplasty. So you see minimally invasive procedure, usually going to go up through the groin. They want this 2 to 3 hours of when they're presenting with any signs and symptoms. So they're going to put that stent in, expand it, and hopefully block all that. Keep it from having the blood clots. Okay, now we're going to get into the different MIs. So what's an acute MI? A disruption or deficiency in that coronary artery blood supply. So as you've seen on that video, which I'm going to find the right video, necrosis of the myocardial tissue, seen it getting dark in there. Most common cause is the arrhythmias. 90% of clients with MI has an arrhythmia, which we know, right? So what is our complications of an MI? Risk of complications will relate to its size and location, which we're going to go through each of those in just a minute. So dysrhythmias is most frequent complication because that pacemaker cells are getting ischemic. So it's going to put off dysrhythmias. That's where we get into our VTACs or VFibs, right? Pump failure, so impaired contractility and filling will produce the heart failure. This risk is greatest when the large portions of the left ventricular are infarcted. So it depends again, where is that location of that infarct? Cardiogenic shock results when functioning myocardial muscle mass decreases by more than 40%. And when we get into shock, we really touch base on the cardiogenic shock. Anybody know what an infarct extension would be? Any idea? That's a little bit hard one. So infarct extension, 10% of patients experience a reinfarction in the area of the original infarction the first 10 to 14 days after an MI. So say they had it around the left ventricle, 10 to 14 days later they have another one. So that is infarct extension. Structural defects could be an aneurysm, some kind of rupture with the myocardia. That's the structure of the heart. And then we talked about pericarditis. So what's our treatment goals when somebody's having a heart attack? We want to relieve that chest pain. We want to reduce the extent of that damage. We want to stop it as soon as we can so not any more of the heart is damaged. Maintain that cardiovascular stability. Decrease that cardiac workload. Again, rest, right? Probably going to be resting. And prevent any complications if possible.
Can you go over the rationale for giving patients morphine type drugs? Why is that one of the first things? Because to me that's counterintuitive. You're giving it to a patient with
You're getting a little ahead of me, Perry.
but you're reducing the chest pain. I understand that.
We're going to get over that in just a few minutes, okay?
Right.
Okay, so how do we diagnose? The cardiac marker, the EKG, the echo, and our hemodynamic monitoring, right? So we're going to go over each of the markers that you need to know. So cardiac enzymes. So here is like how they peak. When you will see them in labs, you know, like the troponin, it may not elevate right away. Carrie, I forget at Avita, do they do them every 3 hours, their markers, their enzymes? It used to be every 3 times 6, but I think a lot of hospitals went to just 2 times. Do you know? Offhand, Carrie?
I have no clue.
Okay, you probably wouldn't see that. But a lot of times, and because they've run into problems, they would do 1 or 2 sets. And if they did them too quick, if you see here, the troponin didn't even start rising for quite a while. So if they did like 2 and, it's not very elevated, let's send them home. Well, they get home and then they have a massive MI because then it really started up. So they like to do at least 2, and they used to be 3 hours apart. They may be 6. I'm not sure. I meant to find out yesterday on that. But it just depends where you work too. Everyone's a little different. But you see how the different peaks are with each of these enzymes we're going to go over. So our first one is your troponin. And like I said, each facility may have a different level. So these are detected in circulation 3 to 4 hours after MI. Still measurable up to 10 days afterwards, so that still may be high. So what we want is less than 45. So for troponin, what I want you to know is less than 45. Now, wherever you work, you may see it a little different. Okay, so I tried to take like a pretty normal one and use that. So troponin is your main one you're going to look at. It used to be called AMI profile. I think they just pretty much changed it and just drew these labs. So
I have a question. So at work the other day, we had someone with troponin levels. I think they started in the 8,000s and then would like slowly go down to 7,000. So what point were they at with an MI?
They was pretty high up there. Now, how many did they have? Do you know, or do you probably don't remember that? But how many levels they did? How many times did they draw it?
I only knew of twice within, I want to say, an hour or 2 of each other, maybe.
Oh wow, that's awful close. Yeah.
Yeah, I think it was.
Yeah. So the next one should have showed it going down. So that I would say was probably their peak. I would hope if they keep going up, then
they started to trend down.
Okay. So was they in ICU at this time or?
Nice. No, they were in the ER.
Oh, okay. I would hope they'd admitted them and done a cath on them.
Yeah, I think we're waiting on beds. That's the classic.
Oh, yeah, that's a bad thing. But so you should see, they should trend down. If they go up, then definitely they're going to need to take care of that for sure. But that is your main one you're going to look at when they think somebody's having an MI. Okay, is your troponin. Another one is your myoglobin. Now, this is not just specific for MI. If somebody falls and damages a muscle, their myoglobin could be elevated, okay? So you need to put this along with the troponin, okay? They need to go together to show an MI. So this can be seen 30 minutes after any injury. So our normal here is 0 to 85, okay? So just because they have a high myoglobin doesn't mean they're having an MI, especially if their troponin is normal all the times they've checked it. So together they make up what we want to look at, but not by itself. You would not want to look just at the myoglobin. And then we have creatine kinase, which can be also abbreviated CKMB. So again, we said MB is specific to myocardial cells. In this point together, levels will increase. You do not have to know these numbers here because they're different. Wherever you work, you're going to get to know, and of course it shows you on there. You guys don't have to memorize that stuff anymore. It shows you when you hover over it if what's normal and why theirs isn't. But so just know those three, troponin, myoglobin, and the CK, is what you're going to mainly see for your patient. Okay, and then also the CBC may be elevated because of the white count. Your ABGs depends on their breathing there, what's going on. The EKG is going to show maybe are they going into VTAC or any other arrhythmia. Echo, is their heart enlarged? Is something going on with that? And any nuclear scans they may have. Collateral circulation, so a lot of people, older people that have an MI, or they may not because of this is actually new arteries that grow to help with the blood flow as they get older. So there you go, Nikki, we got something good on our side. So, but it may prevent them from having an MI, or it kind of helps that their MI is not as aggressive. So this is called collateral circulation. And usually it increases with age. Okay, our sites of our MI. So remember how we went over the 12 lead and I said we would go over this a little bit better. So your main artery, and we've heard it called what? What have we heard that called? Anybody? It's usually right in here.
Widowmaker?
Widowmaker, good. So your LAD, left anterior descending artery, 75% is going to be that the MI happens in, is going to be your LAD. So LAD. So on your 12 lead, this is what's going to show up. I think I got another picture in a minute too. This is the area on your 12 leads that they're looking at to see if it's your left anterior descending artery. This affects the blood flow to the anterior wall of the left ventricle and part of the intraventricular septum. Now we also may hear they're having an MI in the right coronary artery, so your RCA, that provides blood flow to the right atrium, heart ventricles, and right atrial wall. And then there's a circumflex. So these are less percentages. They may have them still there, but the majority of what you're going to hear is your LAD. Now, we'll get into that in just a minute here. Okay. Here again, there's another picture. So again, LAD is considered a widowmaker. It's usually right in this point that the clot happens, that it blocks off. So now we talk about anterior. So anterior occurs when the anterior myocardial tissue supplied by the left anterior descending coronary artery suffers injury due to the lack of the blood supply. So this is where they're looking on the 12 lead. Am I going to quiz you on this? How you find on 12 lead? No. Okay? Because as nurses, are you really going to be going into this? You will, depends on where you work. If you work in the ICU, you're going to learn this stuff really good because you're going to know your patients. But as far as for now, you do not need to know on a 12 lead where this is at. You do need to know about the left anterior, and what it does. A lateral STEMI is a standalone indication for emergency. An inferior MI, which is in this area, which is showing here, it's involved. We have to watch giving morphine because it would drop their blood pressure with an inferior MI. So yeah, we got to know what kind our patients are having to what we're giving for that, okay? Again, that's a doctor's call, right? What is ordered for that? that's why I told you we would go over this. That's why they're 12 lead, because they want to see where that MI is happening. Okay, and the size of the MI, you know, that's determined by the extent of the blood supply, the amount if they have any collateral circulation, and the oxygen demands on that. Okay. And then here again is our zones of tissue damage. So there's our left anterior descending. So there's your T wave showing it, ischemia. We talked about Q waves a little bit, but you can't see it in there anyway. Our ST segment, we're going to talk about that in just a minute. STEMI versus non-STEMI. I know in our clinical group, we've taken care of both of these kinds. A STEMI is a sudden, complete, 100% blockage of a coronary artery, okay? 100% blockage of that heart artery is a STEMI, which means, see here, the ST is elevated. See how your ST is supposed to be like this? It is very elevated, okay? I may look a little different. You know, this is just one of the pictures, okay? So STEMI is a complete blockage, 100% blockage. So if you have those in clinical, look at their 12 leads. See if you see this on their 12 lead. A non-STEMI is severely narrowed artery, but it's not usually completely blocked. So it may be a little depressed, it may not, but it may still show up and considered a non-STEMI. Okay, so make sure you know the difference on those, STEMI or non-STEMI. So clinical symptoms, men, right? We have the classic symptoms: nausea, vomiting. They're going to grab their chest, their arm, like we watched a little bit of that guy in the ACLS videos. Chest hurts. It's radiating down their arm. It feels like an elephant on them. Difficulty breathing. What does women have? What kind of symptoms can women have?
Back pain?
Back pain, yeah.
The indigestion feeling.
They can still have the indigestion, yes.
Jaw.
Yes, jaw pain. I remember when I was in my cardiac clinical years ago, the one woman had a cardiac cath, and we talked to her, and we were like, well, what was your symptoms? All she had was jaw pain. That was it. But they brought her in because of other things, and that's what they found. I had a friend, I talked to her, I said, well, what was your pain when you had your heart attack? She had pain that went up sides of her neck, and then when her chest pain started, her big toe throbbed. Weird, right? You know, so you wouldn't think, oh, it's chest pain, my toe hurts. But so women, very different. Doctors have gotten better at listening to us women. They used to brush us off like, it's menopause, you know, you're just going through that. So doctors have gotten better because so many women have died because they was not listened to. So we have our Red Heart Month in February, you know, all that, because it's better that they're finding ours quicker than they used to. This is actually a picture of my cousin's husband. He has had 25 stents put in, 2 blockages they could not fix. He had a double bypass in 93. So this is his cardiac cath picture he sent to me and said I was allowed to use it to show what he has went through. He's doing fine. He's in his 70s. So it's amazing what people can go through. Okay, we have other diseases that can cause our MIs. So diabetes can increase the risk and worsen that prognosis. So, you know, you have somebody that's diabetic, they're not compliant, they're just thinking, oh, my sugar is going to be high. They don't realize the problems they can cause themselves because of their sugar going so high. So it can elevate the diabetic patient's glucose levels. So yeah, when they're having an MI, it can raise it even higher. So that's worse. Excessive thyroid hormone. It can stimulate that cardiac system, which increase the rate, the stroke volume, and cardiac output. So there's other things that play a role in this MI problem. Okay, so medications. So when somebody's having an MI, the pain relief in treating that MI patient is important. So we want pain stimulates that sympathetic nervous system, increases heart rate and blood pressure, and increases that myocardial workload. So this is what Perry was asking. So the morphine is going to decrease that cardiac workload, okay? Like our guy we had in our lab sim, Walter, I think his name was. He is having chest pain. We could give him the morphine. It would have slowed maybe that cardiac workload down a little bit. May not have taken care of that arrhythmia, right? But it might have helped. He was not working. His heart was not having to work so hard. Yes, it's going to slow your respirations down. So you have to watch on the patients that get the morphine. Fibrolytic therapy. So these are the ones that break down the fibrin in the blood clots. We want to restore that blood flow to the ischemic cardiac muscle to try to prevent permanent damage. Antidysrhythmics, you guys know about that with those dysrhythmias. Beta blockers, these limit that infarct size and decrease the serious dysrhythmias, hoping to catch this, decrease the heart rate, reduce the cardiac workload. ACE inhibitors, again, reducing the risk for heart failure from this. Anticoagulants is prescribed to maintain coronary artery patency following a thrombus or a procedure. Okay, so they may be on heparin, Coumadin, right? And get to know Mona. Make sure you meet Mona. We talked a little bit about her with Walter, but get to know Mona. What is Mona? Anybody know what Mona stands for? Any guesses?
Morphine, oxygen, nitrogen, and aspirin.
Yep, morphine, oxygen, nitrates or nitro, and aspirin. So that is Mona. You will see Mona again, okay? So get to know Mona.
Sorry, what was the A for?
Aspirin.
Okay, thank you.
Pay attention. You're fine.
I'm trying.
Okay, so fibrolytic therapy, as we watched in some of the ACLS videos, they said early administration, right? We want them within 6 hours of that MI. We want to get that blood clot broke up. And if I get the rest of this video to play, you'll see them doing it on him, okay? Contraindicated, of course, in patients with known bleeding disorders, histories of stroke, pregnancy, recent trauma or surgery. So again, did we do the stroke one where they talked to the woman, did she have any history before they could start this, So you have to know their history, what they've had done to be able to give this therapy. Again, we're going to go over more of these treatments next week, okay, with the surgeries. You've seen our guy had the VAD device. Wasn't that interesting, It was I actually seen him. The reason I found out about him from my lecture is he was on a show and he was in California and he's from Connecticut. And they're like, aren't you worried they're going to call you about a heart while you're clear out here? He's like, I can't live my life like that. I have to live and enjoy it. I can't sit home thinking, okay, they're going to call. So he said, I thought, watch another video on him. I think he said when he called, he had like an hour to get to the place to get his heart. So yeah, we'll go over these a little bit more next week. And again, surgery, we're going to go over CABG, the stents, the aortic balloon pump, which I think I got a picture here. Yeah, there's our balloon pump. We'll talk about this again next week. Sits in the aorta, approximately 2 centimeters from the left subclavian artery. As your left ventricle is about to pump out blood, the balloon deflates. So it goes up and deflates. A lot of times they put the patients on these before they get to take them to their cardiac surgery. So it just kind of varies when they use it. So we're going to talk about patients with possible MI. Of course, they're going to have pressure or chest pain. They think they're having a heart attack. Chest pain, they're waiting to see a doctor, a little hard to get in the doctor sometimes nowadays, so they're having chest pain. Oh, it's just GERD, and so they don't go get checked, and these are the ones that usually don't make it. We're just a little bit about what happens in ER. So they get them into bed. They want them to rest. Hook them up that cardiac monitor. They should be wearing oxygen, right? It's usually maybe going to be 2 liters. Give them the aspirin. You know, they always, when you call 911, did you take an aspirin? You know, they want you to take an aspirin. Vital signs. We want to baseline vital signs. We want to be ready if we have to code that patient. Right, Maddie Scott? Obtain a 12-lead EKG. We're going to get those labs, right? We're going to do cardiac enzymes, the CBCs, the ABGs. Just some more stuff. We're make sure they have an IV, right? Again, here's our Monum. We're going to give them that morphine, nitroglycerin. We may give them the thrombolytics. It just depends. Heparin does not dissolve the clots, right? Watch for hemorrhage. Treat those arrhythmias, right? Maybe amiodarone, maybe atropine, maybe epi. And we're going to send them to cardiac cath. Once they get to the CCU, our goal is to keep that oxygenation going, decrease oxygen need, basic care for meds, decrease anxiety, decrease the cardiac output. We were trying to prevent further clots, right? Treat that blood pressure. And nutrition and diet, that's a big thing, especially if they're overweight. Complication, of course, dysrhythmias, treat because they're caused decreased output. They could get CHF from this, could get the APE, could get cardiogenic shock. So a lot of complications can happen after an MI. You know, not you just take care of it and they're fine. They always have to be a kind of watch for that. When they go home, they are going to need cardiac rehab. They may be again on Coumadin or any nitrates. We talked about weight reduction. Could be on beta blockers, anti-anxiety, amiodarone, high blood pressure. Chelation therapy, antidepressants, alcohol, sex education. One thing they tell them, I don't know how many weeks they tell them to wait now. It used to be 6, but make sure it's with the same person in the same place. Don't try something new that gets your heart out of whack. So, believe it or not, people will. Implanted defibrillators, maybe have family know CPR, right? In case this happens again. Our nursing diagnosis, ineffective tissue perfusion, decreased cardiac output, activity intolerance, and acute pain related to. Nursing intervention, we're going to do management of your nitro, your oxygen, medications, rest, exercise. Smoking cessation, right? Need to get them to stop that. A lot of them, this is when they will stop. And that's it for that one. Let's see, what's our time? Okay, let's take another 10 minutes and we'll finish our last one. And like I said, Mrs. Music, she's planning to get on about 12:30ish, so.